is such a huge honor today to be podcast interviewing Dr. Witt Wilkerson, Director of Dental Medicine of the Dawson Academy for Advanced Dental Study, President of the American Academy for Oral Systemic Health, past President of the American Equilibration Society, Leaders in Occlusion, TMD, and Comprehensive Oral Care. I cannot believe it. You graduated from the University of Florida College of Dentistry in 1982. The same year, he joined the Dawson Private Practice Group in St. Petersburg, Florida. You lecture nationally, internationally on the subjects of restorative dentistry, dental occlusion, TM disorders, air sleep apnea, integrative dental medicine. I can't believe I got you to come on the show today. Thank you so much for coming on the show.
Oh, Howard, thank you. It's my honor and privilege to be with you and to just talk about what we're passionate about.
Well, you know, what's really, the reason I'm so excited to get you on the show is because if I podcast interview and I have like 25 different pediatric dentists, they don't disagree about hardly anything. If I brought on 25 endodontists, they pretty much all agree. And in fact, I hate to podcast interview more endodontists because I've already done 25 and they really don't say anything that much different. But my God, when you get to your area, occlusion, Tmj, Tmd, it's like world religions. I mean, my two older sisters went straight into the Catholic nunnery, straight out of high school. My oldest sister's, I've been a dentist 30 years. My oldest sister's been a nun for 35 years. There's no way I could give her a one-day seminar and she'd be Hindu or Buddhist. Do you think TMJ is kind of like world religion? I mean, it seems like there's all these camps and theories and philosophies, or do you think it's really, over the last 3 decades, turned into more of a narrow, exact science like endodontics?
You know, Howard, I don't think that it's become an exact science as you listen to different people and their opinions and philosophies and approaches. But the interesting thing as an observer and clinician and someone who's trying to keep up with the research is that you will hear people saying what seem to be nearly literally opposite things that say they have a great following of successful cases. And I have to tell you, in the last couple of years, I think we may be getting a handle on why that could actually be true. And so that may be something we want to talk about.
Well, let's talk about it. And I also want to tell you that this show is weighted towards millennials. Old guys
Sure.
like me like to go to conventions and read textbooks. And the millennials, they love podcasts, online see. And one of their very specific questions is, you know, that whenever they come out of school, they always complain that they didn't learn enough. They didn't place an implant. They didn't do an Invisalign. They didn't learn enough about occlusion. But they kind of see like it starts off, they need to make a decision between like neuromuscular occlusion and there's equipment that you buy with that, or traditional. What would you call your occlusion philosophy? CR?
Centric relation, yeah.
So talk to, she's 25 years old. She's commuting an hour to work. And her first question is, should I turn right and go down neuromuscular LVI, buy a tech scan, or should I go left and go the CR camp? How would you explain that?
All right. Well, the first thing we want to do is look at the physiology of the people that we're treating. And I know every camp would say, well, that's exactly right, and that's what we do. But the simplest way I can explain it, because this is how we explain it to patients, is we want to know what your muscles are doing. We want to know what your joints are doing. We want to know how the bite fits into that, normally speaking. So if we understand that joints are seated by muscles that pull across joints, and whatever direction those muscles are pulling, that's the direction those joints are going to be seated. So if we're closing our mouths and you've got your masseters and your medial pterygoids and your temporalis muscles primarily firing, then they're going to take those joints up that slippery slope until it hits bottom. And in this case, hits top. And that would be the highest point that the joints can go, you know, against the articular eminence, which would be traditionally a spot that would be called centric relation. So that's a bottoming out point of seating of the joints by muscle, regardless of occlusion. It's before the teeth come together. So if that's what's happening in chewing motions, you remember, Howard, some of the work that was done by Lundeen and Gibbs back in the 80s, where they were looking at chewing strokes and joint position and muscle activity. And what they found is that at the end of normal chewing strokes, the joints were fully seated on both sides. So we take that as the natural physiologic position to start. Another way of looking at it would be like a door on its hinges. So if you've got a door on its hinges and then you close the door, you don't want to run into the frame. And so the door on its hinges would be the joint seated by muscles, and then closing into the bite touching evenly together would be sort of the second half of that equation. There was a well-known prosthodontist back in the 20s and 30s, and he described occlusion as like an inverted tripod where you had a three-legged stool, and he said occlusion is the two legs, which are the joints, fully seated, and then the third leg, which is the bite, fully seated at the same time. So that's what we're always seeking for in a static bite relationship, is all the teeth fit and touch evenly when the joints are fully seated.
These kids are coming out of school $350,000 in student loans, and a lot of them specifically ask, if I wanted to really become an expert in this like you, do I really need to upgrade the practice I bought from a 2D pano to a $100,000 CBCT? Could you do what you do today with a two-dimensional pano, or is 3D imaging really standard of care now in this oral facial pain?
No, I think you could do it with a pano and a good FMX. It depends, of course, if you're going to get into implants and things like that, but that's a different reason. You're talking about occlusion and excellent dentistry, and you can get excellent results using plain imaging. And we did for many, many, many years before 3D imaging came along. So yes, that's possible, sure.
There was a very interesting article written by, it was on Tufts University's website, Oral Facial Pain Fact and Fiction, where they were saying many dentist websites contain inaccurate information about treating temporomandibular disorders, and their conclusion was that oral facial pain should really be a specialty, and that the ADA should recognize oral facial pain as a specialty. What are your thoughts on all that?
I think that every dentist should be knowledgeable about temporomandibular joints, their anatomy, what goes wrong with them, how they relate to the muscles and the bite and the masticatory system. So to me, the temporomandibular joints are just part of dentistry. I don't think that you should have to be a specialist to treat that. Unfortunately, very, very few really know how to diagnose and treat it well, but that isn't because it needs to be a specialty, I don't think, Howard.
Interesting. And back on the money, you know, in so many decisions, money is the answer. What's the question? And again, they have a big debt load. They're also wondering, you know, there's a lot of expensive equipment to buy, like tech scans, things like that. What other type of equipment do you need to do what you do? Do you use these electronic occlusal devices, measurements?
Yes, I do use the T-scan, and I think that it's a valuable tool if you're going to be working with occlusion on a daily basis, which really is dentistry. But I don't think that you have to have a T-scan to be an excellent restorative or occlusal-oriented dentist. And for many years before we had that, we were able to get excellent results. So I don't think that is the only way, let's put it that way, even though it's super, super helpful, particularly the T-scan I'm referring to, because of the fact that you can really quantify occlusal contacts better than you can with articulating paper, where you're looking and you really can't get hard numbers from that. At the same time, we have worked through developing clinical skills whereby both through using your hands to guide the mandible, using articulating paper, getting feedback from the patients, and being very careful, you can get outstanding results using methods that have been tried and true, that are not involving, thousands and thousands of dollars.
You know, the difference between a 25-year-old and a 55-year-old is, they're so bright-eyed and bushy-tailed. They know what they know, but they don't know what they don't know. If you assume that you're mostly talking to kids today under 30. What do you think they don't know that they need to know? And more specifically, how do they stay out of trouble?
Yeah, that's a great question. Well, one of the things that none of us learned very well in school was about occlusion, or about temporomandibular joints, or about airway issues, which of course is a brand new frontier in our work. And so I think every young dentist needs to be aware of the fact that there are many issues that can come up with occlusion, whereby whenever we're doing aesthetic dentistry or cosmetic dentistry, we're affecting the dynamic of the system. And we have to make sure that we not only do no harm, but that we're actually solving problems. So you have a patient with wear on their teeth, there's a reason for that. And the answer to that is not veneers. That's going to make everything go away. So we have to understand the dynamic of the masticatory system, that we're looking at a system, not just at teeth, and that we need to understand the system, that is the joints, the muscles, the bite relationships, and how they have to be synchronized. And now we're adding to that an understanding of the impact of breathing disorders and how important that can be. So, we're learning that young children that can't breathe well through their nose and breathe through their mouths will develop malocclusions, and this can be a source of malocclusion. And so, therefore, if that's a potential, we need to be looking at that as well. Is the patient breathing well? Is the patient sleeping well? Why do people have parafunctional habits like clenching and grinding? And if you listen to some in the scientific world, like Dr. Christian Gimeno, who is the head of the sleep center at Stanford University in California, as he describes upper airway resistance syndrome, where you can't breathe well through your nose, the signs and symptoms of that are exactly what we would call TMD. Poor sleep, waking up tired, clenching and grinding, sore muscles, morning headaches. All of these would be things that we classically would say, well, you've got a TMD problem. If you talk to Dr. Gimeno at the Sleep Center at University of Stanford University, who's a physician, PhD, he'd say, well, that's classic for upper airway resistance syndrome, where you can't breathe well and you're struggling during sleep to get enough oxygen, and you end up with exactly the same symptoms. So what we're learning is there's overlap with these things, and we want to understand those. So to answer your question about the young dentist, I think we need to understand occlusion. I think we need to understand what can go wrong in the jaw joint, including internal derangements, disc problems, off the disc, inflammation, because a cardinal rule of thumb for us would be this: if the joints aren't stable, the bite's not going to be stable either. And you can go in and correct the bite, but it's not going to be stable. It's going to continue to change if the joints are changing. And I would say airway is a subject that relates to that as well. So if we have unresolved airway problems, the patient can't sleep well, they're not breathing, they're clenching, they're grinding, their sympathetic nervous system is excited during sleep, they're experiencing fight or flight type symptoms, and there's stress there, then that can translate into clenching, grinding, moving the mandible, trying to open the airway, episode at the end of an apneic event where we haven't been breathing, that we gasp or clench or brux. See, all these things overlap, and that's what we need to understand.
So, and the overlap is part of those psychological factors, or do you think it's more purely mechanical factors?
Well, I wouldn't stop at mechanical, but I don't think it's primarily psychological either. And I've seen probably several thousand TMJ patients, and I would say I've seen a handful where it was primarily psychological or emotional or psychosocial, but I've seen an awful lot of patients come in who had physical changes and issues going on that had to do with the system either not being in sync or stressed, and as a result of that, having all kinds of problems that once those were addressed, they miraculously better.
So I mean, you've taught over 600 days of classes at the Pankey Institute, hands-on courses. But when you go into the field, the United States has 212,000 Americans have a license to practice dentistry, and in the 80-20 rule, 80% of the offices, if you walk in there and they see a bunch of abfractions, a non-carious lesion abfraction, their treatment plan is just to fill them in with composite. And if you claim that you have TMJ or grinding or headaches or whatever, they simply take an upper and lower algin and send it to the lab and make a bite splint. So they fill in 6 or 8 abfractions and give them a night guard. What do you think of that treatment plan overall?
Well, I would call that treatment plan an effort to manage the problem, but that is different than resolving the problem. Does that make sense? So if you walked in, Howard, and I was a physician, and we evaluated you and found out you had type 2 diabetes, I've got a couple of choices that we understand now in medicine, and that is I can give you prescriptions, and you can try to keep a lid on it with prescriptions, and we'll continue to monitor your blood work. Or we could understand that 90% of people with type 2 diabetes can reverse it with lifestyle changes and get their blood sugar levels back down to normal without medications. Now we're going to have to talk about your diet. We're going to have to talk about other factors that could elevate your insulin resistance, etc. It's the same idea in dentistry as we look at signs of destruction, if you will. We might call that occlusal disease. You know, if you've got notching in the roots of your teeth and wear on the occlusal surfaces and wear facets and flat spots, and you've got cupped out, scooped out areas where there's erosion that may be because of acidity in your mouth. So those are all signs and symptoms of what we might call occlusal disease. Now, we can go in there and patch up the occlusal disease, and we can try to protect you from making it worse by wearing a splint. But we haven't really resolved the problem and probably haven't even diagnosed the cause of why we're seeing these effects. And so our goal would be, if we want to really be comprehensive problem solvers and physicians of the masticatory system and dealing with oral medicine, then we're going to be asking different questions. And that is not what composite do I use to patch or repair that and cover it up, but what's causing it. And let me give you just a really stunning example of how important this is medically, because there's a lot more that we're doing that relates to medicine than sometimes we realize. So there was a study done up at the University of Montreal, and Gilles Levy, who's the dean up there and probably the best known dentist in the area of dental sleep medicine and has done lots of research on it, they did a pilot study, and they took 10 patients who were bruxers and who had sleep apnea and snoring, and then they gave them an upper night guard, just like you're describing. They wore that for a week, and then after they had initially done a polysomnogram in the hospital to measure their sleep and sleep apnea, etc., and they were all diagnosed positive. They had them wear an upper night guard for a week, and then they came back and repeated the overnight sleep study wearing the night guard. And what they found was 5 out of the 10 subjects, their sleep apnea, AAHI, apnea hypopnea index, went up by more than 50%. In other words, their sleep apnea, half the time out of 10 subjects, got worse as a result of wearing the CR night guard that I've made hundreds of through the years for people that brux. And we know that bruxing and sleep apnea are often closely associated. So what that would say is, if you have somebody who has wear on their teeth and you're concerned about that, what you don't want to do is make them a CR night guard without first screening to find out if they could have an airway problem, because you actually could make it worse. What's driving their bruxing could be an airway problem at night. And now when we put our night guard in to protect them from bruxing or protect the teeth, we actually may be making their airway, which could be a life-threatening concern, actually worse. So that's why, the more we learn now, the more we're responsible for. And so we have to understand these relationships, and cause and effect is what we want to understand. And so that's the direction we're moving in the future, Howard. And I think, if this information becomes general knowledge, then dentists could actually get in trouble for making a night guard without a complete diagnosis if the risk is that it could make something like an airway problem worse.
It's almost like dentistry. Do you think dentistry kind of went the wrong direction in 1840 when they created the first dental school in the world, University of Baltimore, Maryland? Because basically the legend has it that the reason they started different dental schools because the hospital needed beds where you lay down, the dentist needed chairs where you sat up, so they kind of departed ways in 1840. Now we're at 2017 and everybody's talking about the oral health connection, integrative dental medicine. Do you think that was a mistake not to have dentistry in 1840 be just another branch like, physicians? They become OBGYN, cardiologists, dermatologists, ear, nose, and throat. Do you think the ear, nose, and throat, they should have done like the Soviet Union where you're a stomatologist, but it's a branch of the med school instead of separating a totally different school? Do you think that was a wrong decision in 1840? And do you see someday the MDs and the DDS getting back together somehow?
I do think that was a mistake, because I think that as this has evolved, it's as if dentistry is not part of medicine. And I think even dentists think of themselves in some cases as, well, I didn't go to medical school, but I did go to dental school. And the fact is that we can probably save more lives through dentistry than any other profession in the healthcare field, because we spend more time with our patients than anyone else. We're looking at the gateway of the whole body, which is the oral cavity. And there's a lot that passes through there, starting with, of course, food, which can be a tremendous source of inflammation if it's the wrong food, and toxins, and also the home of oral bacteria that can, now we know, be pathogens in both the bloodstream and the GI tract. So to me, dentistry is a specialty of medicine, and we're kind of hitting it from the back door, as it were now, some of us that have really engaged in the medical component of inflammation and the oral systemic connection and airway and breathing and how it relates to malocclusion and all of these things, Howard. But we're really, I totally agree with the thought that dentistry is medicine, and it should be a specialty of medicine, no different than being an ophthalmologist.
Well, I mean, it was in 1948 that the Longshoremen's Union, everything that came in and out of this country on a ship, those workers were all the longshoremen, and it was them who negotiated to have dental coverage in 1948, which started the first one, which later turned into Delta Dental. And I think it's very bizarre that they don't even cover an oral cancer screening. Could you imagine what women would say if we stopped taking cervical cancer screenings, pap smears, and didn't cover it? They would claim outrage. Yet sure. You go to the mouth, oral cancer is not covered. You go to the mouth, and when they look at people who die each year from the flu, it's between 8 and 48,000 a year. And they say, when did this person last enter the healthcare arena? And dentists, the dental office, are getting their teeth cleaned is always in the top 3. And dentists, only one state, Tennessee, allows the dental office to give a flu shot, when 49 out of 50 states won't let me give a flu shot, but because I'm a dentist, but they would if I was a dermatologist or an ENT. That's kind of bizarre and weird.
Yeah, it is. And there's so many of these chronic type illnesses that we can pick up on first. I'll give you the classic example is gastric reflux. So there's a whole segment of those that suffer from gastric reflux that don't know it, and they call it silent reflux. And those are people that if you ask them all the questions about sore throat, et cetera, they say, no, I don't think so. But you look at their teeth, and what do you see? You see huge destruction from acids in the mouth, and the dentist looks in there and sees it and says, something's really going on here, low pH. And the vast majority of those people have gastric reflux. The fastest growing cancer in the United States is esophageal cancer. It's like 800% higher incidence now than it was 20 or 30 years ago. And there's reasons for it. But it's largely completely undiagnosed, and probably the number one quickest way to screen it would be to look at people's teeth and see what's going on the occlusal surfaces and the smooth surfaces of the teeth. And when you see that erosion going on that's chemical in nature, you almost certainly have a situation of a gastric reflux type change. And that acidity and what goes on with that coming up from the stomach is leading toward Barrett's esophagus and esophageal cancer and just an epidemic of that. And yet the vast majority of those cases are totally undiagnosed. I saw a classic case the other day, Howard, that literally broke my heart. A gentleman came in to see me as a new patient. I live in Florida. He had moved here from California recently. He was an executive with one of the, I think it was CBS, and he had to stop his career prematurely because he developed esophageal cancer. And he ended up having his whole esophagus removed, and what they do is they stretch your stomach all the way up to your throat and tie them together and eliminate that whole esophageal tract. And it's just horrible. He's living on narcotics. He can't eat many foods. His stomach and everything is upset all the time. But here's what's significant about it is his history is that for 30 years he had sleep apnea, he had gastric reflux, he nearly destroyed all of his teeth. He had his teeth restored because of the severe wear on his teeth. And for 30 years he complained of all these things, but nothing was ever done. And then he was diagnosed with esophageal cancer about 3 years ago in New York City at Cornell. And they told him the reason you have esophageal cancer is because of gastric reflux and very well may be related to your sleep apnea. But no one was diagnosing, and that could happen today. And my commitment in my dental practice is that we screen every single patient for breathing and sleep disorders, and we screen every single patient for gastric reflux. And it's very, very easy to do. You can use a 7 or 8 question questionnaire and give it to every patient walking in your door and get a very good idea, plus just the signs that you see when you're doing your examination. So to me, this is dental medicine. This is integrative dental medicine, and we have a tremendous responsibility and opportunity to be right on the front lines changing lives. And my new favorite saying, Howard, is on a great day, we save a smile. On an amazing day, we save a life. And we've had a chance to do that on a number of occasions where people believe that we did save their lives, and I think we just might have. That should be happening all over the world through dentistry. All over the world, our reputation should be rising right to the top as tremendous screeners and diagnosticians and sleuths of medical issues that are causing people to be ill and even dying prematurely, that are just slipping by because of the fact that most people never get a physical. And the average physician spends 7 minutes, my understanding is the average physician spends 7 minutes every 2 years with their patients.
Wow.
So that's a lot. That says a lot about our opportunity. And dentistry, it's time for dentistry to get on board and say, hey, we are physicians of oral health, and we can jump in there and be on the front lines, and we don't have to take a back seat to anybody. We can learn this stuff. It's not that complicated.
Well, you were talking earlier about, when someone's coming down with type 2 diabetes, you don't do you really want to just take a pill or a hypoglycemic medication, or do you want to change your lifestyle and switch from Mountain Dew, beer, and vodka to water and lose weight and exercise? And that esophageal cancer has changed so much because after World War II, half of Americans smoked. Now it's under 20%. So the old esophageal of a squamous cell cancer from alcohol and tobacco has been going down, and the new adenocarcinoma, you're right, they're saying that they think it's caused by Barrett's esophagus, caused by acid reflux. And when you go into the dental school, would you agree with this statement that they teach mostly about carious disease and periodontal disease, but very little on occlusal disease? Do you think occlusal is undereducated at the expense of caries and periodontal?
Well, I think caries and periodontal are critical, obviously, but I do think that occlusal disease is rarely addressed, and I don't know the reason why, other than maybe there's a lack of confidence in teaching the subject. That would be my guess from my interaction with thousands of dentists, is that it's just, I had a young dentist who came to study with us recently who said he went to one of his professors and asked, when are we going to really learn about occlusion? And the professor said, oh, you'll have to do a prosthodontic residency if you really want to learn about occlusion. To me, occlusion should be the first month of dental school. I mean, everything we do is occlusion. We don't touch a tooth without affecting occlusion. And so that to me is just not an acceptable answer, but it's not an unusual one.
Well, this is Dentistry Uncensored, so I'm going to ask you a couple questions that probably are more born in the barn hillbilly than what you're used to hearing at the Pankey Institute, because that's a very advanced type of student and questions. But a lot of general dentists, especially the young ones, say, hey, come on, if occlusion mattered, teeth, they never touch. The teeth never touch. How could occlusion matter? And then they also go on to say, if all the occlusion, the guidance, I mean, look at orthodontists. They take all these people in canine guidance and blow out their curve of speed, curve of Wilson. They take them from canine guidance to group function. The teeth never touch. What would you say about those two things that you hear some dentists just flippantly say? I mean, you probably don't hear that at the Institute.
Yeah, well, we do. We do. But I would say that in our studies, what we found is that there's two things we can talk about. We can talk about occlusion, which is how your teeth touch, and we can talk about occluding, which is what you do with your teeth. And there are some people who have horrible malocclusions by our standards, where when they close, they only touch on their second molars and that's it. And they just get along great. And those are the people that never touch their teeth. They swallow and their tongue goes between their teeth. Their teeth may go farther apart when they swallow because of tongue habits and those intervening. But the other side of that equation is that we have seen hundreds and hundreds of patients through the years who come in whose occlusions don't look that bad, but because they occlude, meaning they actually bring their teeth together for prolonged periods of time, clinching or bruxing, then everything about their occlusion is important because of the fact that we're trying to not only harmonize what may be a source of reason for clinching and grinding, which can be a malocclusion in those that bring their teeth together, but also we're trying to protect the teeth by having them only guide off of front teeth when they move left, right, and forward, and not banging into back teeth, which were never designed for that. All the studies have shown that when you touch back teeth in excursions away from just pure closing motion or contact, that you turn on the elevator muscles, you turn on the muscles of mastication and actually create more forces and more energy there on the teeth and damage as a result of that. So occlusion is very, very, very important in those that occlude, and a lot of people do. If you see someone coming into the practice and they're saying, I'm in pain, either my teeth are hurting or they're sore or they're sensitive or my muscles are sore, I've got headaches in the morning, they've got wear in their teeth, they're touching their teeth. There's no doubt, and they're doing it for extended periods of time. And so the occlusion is very, very important in that case. And I would add today that we would also pay very close attention to the airway. That could be stimulating sympathetic nervous system response, which means that we have a fight or flight response going on while we're asleep. That is, we're choking to death here. We're not getting enough oxygen. And so you turn on the sympathetic system, you release cortisol in your bloodstream, you speed up your heart rate, and you respond through being aroused or waking up to some degree. And part of that can even be to clench or grind or jut your jaw or brux, these sorts of things. So occlusion is very, very important. Now, the other side of it is, Howard, let's say you take somebody and you're going to be doing some dentistry on them. I don't care if it's cosmetic dentistry, aesthetic dentistry, or they split a tooth, on a hamburger that had a bone in it, and now you got to restore it. How are you going to do that? Does it matter? It does matter, because now you're influencing the system and how things are fitting together. So we always want to move in the direction of more ideal and never causing problems. And we've seen fair percentage of the patients we see in our practice here, working with Dr. Dawson for 35 years, we have patients coming in from all over the world. And I would say the number one source of referral would be severe wear. People who are wearing down their front teeth and back teeth and chipping and breaking teeth. And so there's a sign there of a cause and effect relationship that we need to resolve. And whether you're doing veneers or, covering teeth that have broken fillings or whatever it is, there's something going on there in the system that needs to be addressed and idealized in every case. So that would definitely be our perspective on that, and we've seen a lot.
Again, every time I ask my homies, I'll say, I don't know who's listening to this on iTunes. It just gives me a number of how many and what country they're from. Shoot me an email, howard@dentaltown.com. Tell me how old you are. I was really surprised by that. So many of these emails are coming in, and they're saying, I'm applying to dental school. I'm D1, D2, D3, I can't believe how many of these kids are dental students. So again, that might explain a lot of the questions I'm asking you, but help her with verbiage. The patient comes in, and a lot of times they say, I have a click in my jaw. What should she be thinking, saying, doing, diagnosing when the patient's saying, hey, doc, I have a click in my jaw, or my jaw is locking?
Right. Okay. Well, if we understand the very, very basic anatomy of the joint, then we all remember in studying anatomy, at least a little bit, that you've got a condyle with a disc on top, and that disc is attached on the inside and outside corner. We call that the collateral ligament attachment. So it's like a bucket handle that's rotating around the top of the condyle or the ball in the socket. Behind that, those two ligaments on the sides is a ligament that goes to the back wall of the condyle. We call that the posterior ligament. And that ligament is like a tether. It prevents the disc from coming forward or slipping forward. And then up in that behind the disc area is a tissue that we call the retrodiscal or the superior strata of tissue, which is like a sponge that engorges with blood. When you open your mouth wide and the condyle goes down and forward and glides down and forward in the socket, it doesn't leave a vacuum behind, but it engorges with blood. And that blood-filled vascular innervated tissue is right behind the disc. So when you have someone come in, they say it's clicking, typically what that means is, as a minimum, the disc where it's attached on the outside corner, the lateral corner, is probably either lax or torn or stretched in such a way that the disc is slipping forward. And when you open and click, you're clicking back underneath that corner of the disc. And when you close, you may hear a reciprocal click where it clicks again and it's slipping back forward. That's the most common click. And about a third of our patients that are adults may have a click on one or both sides. So this isn't rare to have some type of change going on inside of a jaw joint. Fortunately, the majority of people that have a click, it's a lateral pull off the outside corner, slip just a little bit, and you're crisscrossing on that corner, and it may never get worse. And so people may say it's been doing that for 5 years, 10 years, 15 years. It doesn't bother me. It's not hurting. Maybe they had an injury there in the past, and that affected the integrity of the disc on top of the condyle, and we have that crisscrossing on opening and closing. So in the presence of no symptoms and no changes, it can be something that's innocent and will not require necessarily any treatment at all, Howard. But in many cases, particularly when you see this in younger people, so if you have a 16-year-old, 18-year-old, 20-year-old young female coming in, their susceptibility to developing progressive jaw joint problems is greater than a 45-year-old man who says, yes, I have that on that left side, and it clicks like that, doesn't bother me at all, and it's been doing that since college, and I played sports and probably heard it back in high school when I played football or something like that. So that man who is 45 with an innocent click that's been there for a long time probably isn't going anywhere. It's probably not going to turn into anything. But when I see a young female come in and she's got clicking, or as you said, locking, which means maybe the disc now is stuck in front and they're not able to negotiate getting back under it, and they actually have a mechanical blockage to opening, which would be probably the most common reason for that locking, then you're thinking about something that actually could be progressive and get worse and worse, and you really want to study that and understand it and look very closely at it. If someone comes in with a click, and especially a painful click, or as you were saying, a lock where they're getting stuck, then the bottom line is the first step is diagnosis. And so a diagnosis of a joint problem like that that seems to be significant would involve getting some imaging. And so the gold standard for imaging a temporomandibular joint that is painful or that has soft tissue issues like clicking and locking would be an MRI. And an MRI can be done today whereby you can actually see the disc, you can see obviously the hard tissue of the bone, you can look at the disc and its position all the way from the inside corner to the outside corner in slices, and you can precisely see what's going on. You also can see if there's fluid in the joint, which there may be edema or fluid in the joint, and that can be a source of pain. That fluid in the joint can be back in that retrodiscal tissue where it's innervated and vascular, and that'll swell when there's problems inside. So to answer your question, the first step in a joint problem that is symptomatic or may be progressive would be to get a good diagnosis, and that is to go inside the joint and look at it. It's no different, Howard, than if you came in with a clicking knee, and you may have a tear in your ACL, or you may have a meniscus tear and some tethering there, and you're getting swelling in that joint and problems like that, some discomfort. It's very similar to that. And what would the orthopedist do in that case? They would get an image of the joint and take a look inside and see what's going on so they can get a clear diagnosis that can be the basis of what their options might be for treatment.
When someone comes in with temporomandibular disorders and they're in pain, do you ever utilize pharmacology?
Oh, sure. Of course, anytime there's significant pain, you're going to use pharmacology. So if someone came in and they were holding the side of their jaw in the area of their joint and they said, it's just killing me, the first thing we'd probably do is give them a Medrol dose pack and say, well, let's hit it real hard for the next 5 or 6 days with a good steroid and see if we can reduce the inflammation and edema that may be in that joint and see if that gives you some relief. So that would be a first step. If someone has severe muscle issues going on and they're just really in knots as a result of a jaw joint or temporomandibular problem, then we wouldn't hesitate to give them a muscle relaxer. And one of my favorites is diazepam, which is Valium, in very small doses, like 2 milligrams. It doesn't affect the way you feel. You don't feel groggy. You don't feel sleepy. You don't feel, compromised. And yet the muscle discomfort will often subside quite quickly. So we might take someone who comes in with an acute problem and put them on a Medrol dose pack and give them a prescription of 2 milligrams of diazepam to take 3 times a day, and soft diet, non-chew diet, and give it 4 or 5 days and see what happens, especially an acute problem like a injury or something like that.
I know you're a busy man, and I was so grateful to get an hour. Do you have any more time, or tell me when I need to let you go?
Oh, sure. I've got another 5 or 6 minutes, Howard.
Okay, I want to ask you, this is Dentistry Uncensored. I don't like to talk about anything anyone agrees on. Let me ask you a big controversy. That there's, anyway, you said earlier that occlusion is that TMD, TMJ, you said an inverted tripod. You got 2 joints, and then you got the teeth touching. Some dentists and orthodontists, when they see a patient with TMD, they say, I want to unravel your teeth with braces. I want to let your joints be seated and bring your teeth together, and I'm going to use orthodontic treatment as a major component of treating your TMD. Other people say that's just crazy. How do you weigh in on that?
Well, I think it depends on the diagnosis. So if you have somebody that is like one that we just spoke about, they have an internal derangement, they're off the disc, then the first thing we want to treat definitively is the joint problem. And so whether it's working with trying to stabilize it, with working with we might use an occlusal splint that would even the bite out and reduce some of the stresses in the joint of closing and biting together. If they're clenching, we can use anti-inflammatories and etc. We may, in some cases, reposition the mandible just slightly for a period of time to try to decompress slightly the joint. But the bottom line is we're not going to do anything irreversible with the bite until we've got the joint stable. I said earlier that a rule of thumb is if the joints are unstable, the bite will be unstable. So that would imply that we're not going to go in there and just perfect the bite and expect that to heal a damaged joint any different than putting a knee brace on your knee is going to solve your anterior meniscus, anterior cruciate ligament tear or something like that. So if there's damage in the joint, we need to get that stable to an acceptable level, even if it included surgical intervention in some cases, which is not that many, but there is an appropriate time for surgery in the jaw joint. We want the joint stable. Now we're going to look at the occlusion. I see patients all the time coming in to see us who are in misery, and I would say half of them have braces on their teeth. And we do an MRI, and they're off the disc, and they've got fluid in their joints, and they've got edema and swelling in the retrodiscal tissues, and they're loading on retrodiscal tissues, and they're in a lot of pain, and they've got braces on their teeth. And I'll ask, well, why do you have braces on your teeth? Well, I've got braces on my teeth because they said if we straighten my bite out, that would help my jaw joint problem. And you see, we're not thinking like orthopedists if we say that, because we're not thinking about damaged joints and what it takes to correct a damaged joint. It's not by just making them a nice bite in the front. And so I have a problem with that, and no different than someone who has an internal derangement in the joint, and we say, well, we're just going to do orthognathic surgery, and that's going to heal it. I've seen people that have had orthognathic surgery, and 6 months later, their bite, to correct their bite, and 6 months later, their bite is wide open in the front because they're still breaking down in the back. And yet they've gone through major, major surgery, as you know. And so we want to be really, really careful about that.
Last question. We have 50 categories on Dental Town on the message boards, and one of them, of course, the number 50, because it starts with T, TMJ, TMD. A young student asked, earlier you described, when I asked you about pharmacology, you said when a patient comes in, they're holding their face, they're in pain. She asked, how can you tell the difference between an earache and joint pain? When they're holding that area,
Sure.
what's going on in your brain to decide, is this an ENT problem or a dental problem?
Right. Well, of course, you have to ask good questions about their history and what they're experiencing right now. So if someone's pointing at their ear and I don't identify anything going on with the jaw joint, then I'm going to refer them to an ENT right then. But I see a lot of patients who come in, they say, I've already been to the ENT and they sent me to you, because they don't think there's anything wrong with my ear. They think it's in my jaw joint. So the truth is they can overlap. And so if you've got swelling and the edema we were talking about in the damaged joint, then it can cause problems in the ear for sure, and vice versa. So I would say we want to get clear diagnoses, and we need to take whatever steps or measures that are necessary to get to the bottom of it. And sometimes that means I need help from my physician colleagues. And other times we may try something for a few days and see if there's a response. So to give someone a Medrol dose pack and a muscle relaxer, if they're coming in saying, I'm having pain on the side of my face and my muscles are hurting and I've got a headache and I can point right to the joint area and that's sore, that wouldn't be, there'd never be a contraindication to doing that over the course of a short period and seeing if there was a response. And whether it was an ear problem or a joint problem, we probably would get improvement in many cases using something like a Medrol dose pack.
So, final question. If she's listening to you right now and she says, I didn't learn enough of this in dental school, I want to learn more, what textbook or courses, or you teach at the Pankey Institute, give her your pitch on your best book and best course at Pankey, or to see you to learn more about this.
Yeah, actually, Howard, I've taught at the Pankey Institute, but I teach at the Dawson Academy. So we have courses throughout the year that will, and you can go on the Dawson Academy website, that will address temporomandibular joint problems, occlusion, and diagnoses. And then we have courses on airway problems and integrative dental medicine and all of these topics. So those are all addressed through our curriculum, and I'd invite them to go to the Dawson Academy website and take a look at that, because everything we're talking about is right in the center of what we're addressing with now over 40,000 dentists that have been through the Academy for training.
Well, a lot of these millennials follow me on Twitter, so I just went to Twitter and retweeted the last tweet from @Dawson Academy. I just retweeted a quick tip, how to increase your confidence in treatment planning, and the other one, a couple of their tweets, but that is amazing. The millennials also love online C. It would be beyond a huge honor if you would ever create an online CE course. We've put up 450 courses on the Dentaltown app, and they're coming up on 1 million views. I think it'd be a good hour to go over what they don't know, and I think it'd be the best marketing for the Dawson Academy or your courses so they can learn more about occlusal disease.
Yeah, and we're planning to do that, Howard. We're all set up to do that with you all, and we may do 2 or 3 things. So I'm looking forward to doing that probably between now and Christmas.
Witt, you are an amazing man. It was such an honor to get someone of your caliber to come on the show today and talk to my homies. Thank you so much for giving everyone a precious hour of your life today.
Well, it's my greatest honor, and thank you, Howard. I appreciate what you're doing to change the world.
Oh, you're too kind. Have a great day, Witt.
Thank you.
By the way, one last thing. Your dental office, by the way, just go to your website. That is the most gorgeous dental office around. I mean, everybody would be so lucky to practice in that office. What a gorgeous office.
Well, you're so kind. And if any dentists are listening to this or ever in St. Pete, Florida, please have them pop by and say hi to us.
Okay, we will. Thank you so much, Witt.
All right, Howard. Have a great afternoon.